Hello, everybody. Welcome to Metabolic Dysregulation, still part one, pathophysiology. We're going to start talking about metabolic syndrome and diabetes now. All right, metabolic dysregulation and metabolic syndrome. Here are some resources on metabolic syndrome, some from the NIH, just basic information. So here's the criteria. We've already talked about this a little bit. We know that if you have any of these three criteria, then that is considered diagnostic of metabolic syndrome. And we look at dyslipidemia, so triglycerides and HDL cholesterol. So if your triglycerides are above 150 milligrams per deciliter, or looking at HDL, if your HDL is low, so less than 40 for male, less than 50 for female, if the individual has insulin resistance or an elevated fasting glucose. So the criteria would be a fasting glucose of 100 milligrams per deciliter or greater. Abdominal obesity. Sometimes organizations, there's some different criteria. They'll look at body mass index, but a lot of people would prefer to have that the actual measurement, the abdominal obesity. So for a male, over 102 centimeters or 40 inches. For a female, greater than 88 centimeters or 35 inches. And then blood pressure. If blood pressure is elevated, 130 over 85, that would be diagnostic. So any three of these five, of course, you could have all five. And of course, it can be beyond this into a disease state versus just above normal. Of course, when we look at those variables that make up metabolic syndrome, the more of those criteria you have, the greater your risk is going to be for things like cardiovascular disease. In fact, the risk is twice as high for heart disease and stroke, 5 times as high risk for diabetes. So people progress from these. Again, even though they're not disease state themselves, when you pull them all together, bam, we have great risk. And here what I have is just showing the connection to inflammation. This was actually from my research. And what we found was that as the criteria for metabolic syndrome increased, the C-reactive protein increased. And of course, since I did this, there's been lots and lots of studies showing this. All right, so there's obviously a lot going on here, and this is a pretty detailed slide, but it's a great image of what's happening during metabolic syndrome and all of the dysregulation that occurs and how our drives to eat actually increase through this process of dysregulation. So I'm going to start with obesity because it's a good place to start. But of course, as obesity increases, we start to see an increase in inflammation. So as this low-grade inflammation increases, then other organs are going to start being affected by this. And that involves, this metabolic homeostasis. And then they begin to do a poorer job of responding. And so they're not doing a great job of keeping things in homeostasis. So it kind of trickles down. We start to see one failure after another. And then, of course, the visceral fat, that belly fat, is especially affected by this, and it contributes to increased inflammation. We talked about those fat cells and the macrophages within the fat cells and all the chemicals that they're producing, the cytokines. And then, of course, the brain starts to do a poor job of regulating the size and the frequency of the meal, which can then lead to more weight gain, which actually creates even more dysfunction. And of course, the autonomic nervous system, that HPA axis, they start to get more disrupted. We start to see that the GI tract gets disrupted as well. The microbiota begin to change, and they release, and the release of gut hormones starts to change. So things like ghrelin. There's others we haven't talked about, like GLP-1 and CCK. There's a lot of different hormones that are involved in appetite control, and they get dysregulated. And part of this is through some of the changes of the gut bacteria. So again, that gut bacteria is really important. And so now we start to see tissues, organs, they start to ignore insulin. We start to see insulin resistance or prediabetes. And then the pancreas cells, they start to expand to release more insulin. So they're now working harder to overcome this state, which then leads to elevated insulin So we see more hyperinsulinemia. So now we've got elevated insulin, now we've got elevated glucose, and we've got the fat cells that are working overtime and producing all these hormones. The other hormones aren't working well. Now, looking specifically at the islet cells within the pancreas, they start to wear out. And then, over time, this is over time, as somebody has type 2 diabetes for some time, then those cells that produce insulin, they can't do their job. And of course, now we're getting less and less glucose into the cell. So with this, during pre-diabetes and having chronically elevated glucose levels, this basically starts to poison our cells. All this excess glucose starts to poison our cells, and there's even a term called glucotoxicity. And glucotoxicity, so the glucose is toxic to our cells when we have too much of it. And insulin resistance in the liver, of course, that contributes to that glucotoxicity. Then it alters the hepatic glucose production after we eat, leading to increased glucose levels. Again, we create all these vicious cycles. And then the insulin resistance, that prevents the muscles from taking up that excess glucose when it goes back to the liver. And then again, the liver is dealing with this. Of course, we've talked about, when you think of the fructose, when we get all this excess fructose, and that's hitting the liver fast, and the liver is having to deal with that and packaging up into triglycerides. So we start to see that non-alcoholic fatty liver. Again, we begin to store all this fat, and it's causing damage to the liver. And then, of course, this can worsen insulin sensitivity. So now we're even less sensitive to insulin, even more now. And the insulin resistance is also going to lead to this desynchronization of the circadian clock. So now our sleep is all messed up. And excess fat can then be released from the liver and go into the form of the lipoproteins. So they're converted to those VLDL, those very low density lipoproteins, which then can lead to elevated triglycerides, which of course we've talked about being a risk factor for cardiovascular disease. And the fat cells, due to the insulin resistance, release more fatty acids, which leads to lipotoxicity or lipid toxicity, which which then starts to lead to other organ dysfunction and disease. So that's basically what this slide shows. It's all of this mess of dysregulation. If we can lose weight, if we're starting with obesity in this process, well, let's start with obesity in changing this process. We know that even just 10 pounds of weight loss can have a dramatic effect on our risk of disease, dramatic effect. So we need to start getting weight down. I mean, it's obvious. We all know this, but it's not as simple as it sounds. But I really think we need to take the approach of looking at the emotional side of this, basically going back to what we were talking about in the obesity lecture. So this is just a slide sort of recapping some of the things that we were just talking about and giving it to you a little bit in written form. So we see reduced metabolic feedback signals to the brain, the higher areas of the brain, reduced metabolic feedback signals to the areas of the brain that are involved in feeding. We see less efficient adipocyte signals like leptin and insulin into the brain, defective regulation of endogenous glucose production, unbalanced energy intake and utilization, defective glucose sensing. So basically adipose and gut hormones, they're less efficient, and satiety signals are less efficient. We see that desynchronization of the central circadian clock, so we have disruption of our circadian rhythm. We see the GI tract getting disrupted, the gut bacteria are altered, and we can have that leaky gut syndrome, and that's a whole other thing we'll talk about in another lecture. Of course, the chronic inflammation, increased oxidative stress, increased risk of type 2 diabetes, effects on the, even more dysregulation within the glucose tolerance, and cardiovascular disease increases, and of course we have that non-alcoholic fatty liver. So there's just a quick semi-summary of that diagram. This is kind of an interesting study looking at metabolic syndrome and the association with vitamin D. And this particular study was in postmenopausal women, But I wanted to point out before I talk about the study, what's considered normal. So when we look at vitamin D, you measure the hydroxy vitamin D in the serum. So you do a blood draw, they'll measure the hydroxy vitamin D. So anything that's above 30 is considered within the normal range. And then if you look at a range of 20 or less, if it's less than 20, that's considered to be deficient, like you are low. So that's vitamin D deficiency. Anywhere between 20 and 29 nanograms per milliliter, that's considered insufficient. But 30 is on the low end of normal. And when you look at the research, not just the study here, but just research on vitamin D in general, people that are on that low end are really, they're just not as protected. We know that the protection of vitamin D typically is in the middle or the upper end of the range. So we really want to try to increase vitamin D, and so many people are low. We've really got to get people get the blood test done. If you haven't done it, do it. If your clients haven't done it, have them get this checked, because it's so instrumental to our health, and not just because of some possible effects on insulin sensitivity and influencing metabolic syndrome from that perspective, because that may be one of the mechanisms by which we see some changes in or increased risk of metabolic syndrome. But what they found in this particular study was that a lot of the women were low. So if you look at, of those that were measured here, about 30, a little over 32% were insufficient, had insufficient levels of vitamin D, and a little over 35% were deficient. So a larger percentage were actually deficient in vitamin D, and then about 32% fell within the normal range, so 30 or above. But of those women that were low, so both the insufficient and the deficient, about close to 60% of them had metabolic syndrome. So there was an association between metabolic syndrome and low or insufficient areas of vitamin D. So again, something that we really need to start measuring.